I'm going to talk about nerve transfer surgery applications to tetraplegic patients. Every 8 hours in the UK and Ireland, someone sustains a spinal cord injury. 1,200 new cases per annum are seen, and the long-term care needs cost approximately £500 million per year. 70% of these spinal cord injuries are traumatic in origin, and 70% affect men, generally in the young age group. 50% of cases are of tetraplegia, and in 50% of these there's some preservation of proximal upper limb function. So there's an estimated 151 new cases of paraplegia with brachial diparesis, as perhaps it's more aptly known, every year in England and Wales. The lifelong costs, based on an American study of looking at someone with a high level tetraplegia, are approximately $4.5 million when the patient is 25 years old at the time of injury, and in a low-level tetraplegia the costs are nearly $3.5 million. So what are the upper limb priorities in treating a tetraplegic patient? Well, patients would normally have their treatment in a specialist spinal cord injury centre, and the aim is to increase independent function. So this can be done in two ways. The first is through therapy strategies to optimize the current functional level, strengthening preserved muscles, preventing joint contractures through passive range of motion and muscle stretches, managing spasticity and using splints and orthoses. The next phase is to think about improving functional level, and this can be through referral to a specialist tetraplegic upper limb centre. Here there may be further specialist non-surgical management with botulinum toxin and splints, but there also may be surgical management with either tendon transfers and tenodesis procedures or nerve transfer procedures. Historically, it was thought that only about 5% of tetraplegic patients would gain any benefit from having tendon transfer reconstruction in their upper limbs, and this was well established by Gutzman and others. But there's been conflicting evidence, and a report by Moberg suggested that 75% of tetraplegic patients would have functional gains from upper limb surgery. A paper by Wual in 2003 said 70% of patients were satisfied and 68% had documented and recordable improvements in activities of daily living following upper limb tetraplegic reconstruction. And a review of epidemiological data from 1988 to 2000 in the USA identified that only 7% of appropriate surgical candidates actually received surgery. And that was from Curtin. There was a survey in 2004 by Snook et al., and this was published in Spinal Cord. This looked at the needs of patients with spinal cord injury and the impact and priority for improvement in hand function in tetraplegics. And improving hand function in both Dutch patients and also in UK patients with tetraplegia was ranked above improvements in bladder and bowel function, compared to paraplegic patients who had normal hand function, where they rated bladder and bowel sexual functions much more highly. Simpson et al. In 2012 also looked at the health and life priorities of individuals with spinal cord injury through a systematic review. What they identified was in numerous papers in tetraplegic patients, arm and hand function was rated higher or as high as improvements in bladder or bowel function. When the opinion of patients treating tetraplegia are surveyed, there is a contrasting perception between physiotherapists and hand surgeons. So physiotherapists rank upper limb function lower than surgeons in tetraplegia. There's obviously a lack of clarity in the literature about outcomes, a lack of access to reconstructive services, and a lack of experienced hand surgeons and therapists, which all suggested in this paper as reasons why physiotherapists may rank hand function priorities lower than those of specialist upper limb surgeons. It's also felt that there's a negative bias between GPs and spinal cord injury specialists towards reconstructive surgery. Interestingly, in units where a good relationship exists between spinal cord injury services and hand surgery reconstructive services, there was a 2.8-fold therapy referral rate for hand surgery interventions and a 13 times surgical reconstruction rate undertaken. Despite the high priority given to improving hand function in tetraplegic patients, the uptake of tetraplegic limb reconstruction is actually variable. A few studies have been undertaken by Dunn in New Zealand, and one showed that the uptake was only 59% in patients who were assessed and eligible for surgery, and it was estimated that only 44% of the eligible population as a whole actually took up the offer of hand surgery. A further paper looked in detail at 22 patients, 10 of whom had surgical treatment and 12 non-surgical treatments, and it looked at their decision making in terms of trying to improve function. Generally, for those wanting to have surgery, they were trying to increase their functional level and their independence for activities of daily living. But amongst those seeking non-surgical management, there were two common themes. One was on poor social and family support for the duration of the surgery and recovery period, and the second was centred on the hope of a future cure for paralysis. In New Zealand, there's been the development of an international upper limb surgery registry for treatment of people with tetraplegia. And this has actually identified that only 223 out of 357 eligible patients have actually been given hand surgery treatment. So I undertook a survey of tetraplegic upper limb reconstruction in the UK, and this was a British Society for Surgery of the Hand member survey in April to May 2004 using this SurveyMonkey tool. 10 questions were circulated to the 320 full members through email, and 66 respondents with a 20% of eligible membership was achieved. What the study showed was that the breakdown between plastics and orthopaedic surgery specialties was as is typified by the membership, with nearly 30% plastic surgery and just over 70% in orthopaedic surgery. And of those who actually responded to the survey, about 40%, or just short of 40%, were full-time hand surgeons, and just over 40% undertook 75% of their practice in hand surgery. The geographical location of the respondents was mapped towards the 12 spinal injury centres in Southern Ireland, Northern Ireland, Glasgow, and then the rest of England and Wales, with a good mix apart from Southern Ireland. This would reflect the BSSH membership. When asked whether there was a local protocol or pathway in place for patients with tetraplegia, 12% of respondents said yes, and then the remainders either didn't know or said no, there was not. When asked to name the specialist in tetraplegic upper limb reconstruction in their region, 85% of respondents weren't able to do so. The majority of the respondents didn't undertake any tetraplegic hand surgery at 85%, and 15% of respondents who did were named and questioned further. In terms of how many new cases of tetraplegia each surgeon saw per year, there were less than 5 patients seen in 24% of respondents, and between 5 and 10 in 3% of respondents, and between 10 and 15 in 3% of respondents. When asked how many surgical cases of tetraplegia were undertaken per year, the majority responded none, but less than 5 cases were undertaken in 9 respondents, and between 5 and 10 in 2 respondents. 2 questions were then asked about reconstruction to look at the practice within the UK. In a C6 tetraplegic, I believe that elbow extension is best restored by, and the options included deltoid to triceps transfer, biceps to triceps transfer, nerve to teres minor to long head of triceps, axillary nerve transfer to radial nerve, or don't know. Here, the majority of respondents didn't know, and then the traditional tendon transfers were 21 and 22%, with just one person opting for an axillary nerve transfer, and 4 people, interestingly, opting for the Bertelli transfer that's been described in the last few years, taking a nerve to teres minor and transferring it to the long head of triceps. The second question was about brachioradialis function being the most distal function, asking what the optimum hand function achievable is. And here again there was a variability in respondents. 1.5% of the surveyed population believed that nerve transfer could be used to restore a tripod grip. What this highlights is there is poor awareness of local referral pathways, lack of protocols. There's no centre undertaking more than 1 case per month in the UK, and based on exaggerated estimates, it would seem that approximately 80 patients are offered an assessment per year, and at a maximum 72 procedures could be undertaken per year. It's interesting that 7.5% of the respondents, and these were all in people undertaking upper limb reconstruction, believed that nerve transfer surgery was a way of achieving elbow extension. So when should any reconstruction be undertaken? Well, the acute injury duration is between a week and 3 months, and this is when the patient will be moved from their main hospital towards the spinal rehabilitation centre. The spinal cord injury rehabilitation for a tetraplegic patient is approximately 6 months. If you look here, for new injury, 583 patients presenting in the study period through the Spinal Injury Association survey, published in 2009, shows 177 days in the spinal injury unit for a C5 to C8 level injury. The aim of the spinal cord injury rehabilitation is to improve the general level of fitness and well-being of the patient, and during this phase, hand and or upper limb surgeons should review the patient, and ideally by 12 months. Once it's established there's a stable deficit with no recovery potential, reconstruction should be offered sometime between 12 months and 2 years. Now, upper limb reconstruction in tetraplegia is not actually straightforward in terms of deciding what procedures are best to be undertaken or offered. In a C5 level, some patients with a grade 0 IC-SHT would have deltoid function but weakness of biceps and brachialis. In a grade 1 level injury, there would be a function of brachioradialis but no wrist extensor function, and then a mid-level tetraplegic patient would have a grade 3 level injury with reasonable wrist extension through ECRL. A grade 4 level would start to have pronator teres function, and a grade 5 level some function in the flexor carpi radialis, although it would be weak. Grade 6 level function would have some finger extension. A grade 7 level would have some thumb extension. An 8 level some digital flexor. A 9 level lacking only intrinsics, and then exceptions. So the traditional aim of reconstructive surgery in tetraplegia is to improve the functioning level. So for instance, in a group 2 injury patient who's got oculocutaneous sensation, IC classification 2 without triceps, posterior deltoid could be transferred to triceps, or a biceps to triceps tendon transfer could be used to achieve elbow extension. Brachioradialis would be needed to improve wrist extension to enable a palmar grip, and that would be done through a tenodesis action. Wrist extension through ECRL would be too weak. There is no good key pinch restoration possible unless ECRL is functioning still. Now, the principles of nerve transfer involve taking a fascicle or a motor branch from an intact nerve and rerouting it close to the end plate of a defunctioned or denervated muscle. So reinnervation times are very rapid. A paper published by Susan McKinnon, which was a case report looking at restoration of a prehensile grip using innervation of the nerve brachialis to the anterior interosseous nerve, has demonstrated that function can be achieved even many years after the spinal cord injury. So this was the technique that was used. The nerve brachialis was transferred into the anterior interosseous nerve.
Surgeons at Washington University School of Medicine in St. Louis have developed a procedure that may help restore some hand function to quadriplegic patients with spinal cord injuries in the C6 and C7 vertebrae.
This was a remarkable step forward for
surgeons at Washington
Reconstruction
University School of Medicine in St. Louis.
Justin Brown's published in Surgical Neurology International a review article looking at strategies to improve function in tetraplegic patients, and he describes techniques for restoration of triceps using fascicles taken out of the axillary nerve. They can also be used to transfer into the posterior interosseous fascicles of the radial nerve in order to try and achieve finger extension and triceps function. And the principle here is interfascicular branching, so you can sacrifice one fascicle between motor branch points without completely denervating the proximal muscle. So the role of upper limb reconstruction in tetraplegia is expanding and developing. A number have been described to date, including axillary nerve fascicle transfers to the long head of triceps, axillary fascicles into the posterior cord or the posterior interosseous nerve component of the posterior cord, teres minor branch transfers to the long head of triceps, the Bertelli technique, brachialis nerve transfer to the anterior interosseous nerve as described by Susan McKinnon, and there is a study going on in British Columbia at the moment looking at supinator branch transfer to the posterior interosseous nerve. Now, when considering the cervical spinal cord in tetraplegia, one has to recognise there are three distinct zones, and this is taken from Justin Brown's paper. There's a supralesional segment, which is the intact zone with volitional control and normal strength and reflexes. Then there's the injured metamere. This is the zone of injury where the anterior horn cells have been lost, there's axonal degeneration, and it behaves like a peripheral nerve injury with motor end plate degeneration. And then there is the infralesional segment, and that's where there's anatomical integrity, there's loss of descending inhibitory synapses but an intact reflex pathway, and latent nerve transfer is a possibility potentially in these patients. So the principles of nerve transfer surgery are well established but can be applied to tetraplegia. The recipient nerve needs to be coapted as close to the target muscle as possible to shorten the reinnervation time and minimize the denervation motor end plate changes. The donor nerve has to be from a muscle whose function is expendable and sufficiently strong, or one that has redundant innervation. And using a pure muscle donor with sufficient axons is mandatory. Using a donor with a good size match to the recipient nerve, avoiding grafts, and ideally using a donor from a muscle that is synergistic are all optimum strategies. Motor re-education improves function post-operatively. Now, the advantages of nerve transfers over traditional tendon transfers in tetraplegic reconstruction are numerous. Tendon transfers require more dissection and longer post-op immobilization, and scar may restrict motion in other tendons. Tendon transfers must be staged, so it's not possible to undertake extension and flexion transfers at the same time, and that increases the recovery time and dependence on others for activities of daily living. Tenotomy does actually reduce the muscle force in already weakened muscles. Nerve transfers require minimal periods of immobilization, and there's less loss of donor muscle function. Nerve transfers have a greater functional gain for a given transfer, so more than one muscle may be reinnervated, and multiple independent functions may be realized due to cortical plasticity than compared to the single functional gain of a tendon transfer. Nerve transfer may be used by using a single fascicle from the donor without weakening the donor function through the concept of interfascicular branching and the process of axonal sprouting, or adoption as it's termed. Now, there are a number of important trials are underway looking at nerve transfer surgery. Two of note are from British Columbia, looking at supinator branches into the posterior interosseous nerve, and a trial from WashU University St. Louis, looking at nerve to brachialis to anterior interosseous nerve function. So when should you undertake it? Well, it's important to establish that there's a static or non-functional grade of motor recovery. So we know from Frankel's studies that MRC grade 1 or 2 may improve to a 3, but rarely beyond that. Optimizing physical status of the patient includes improving respiratory function, reducing BMI, pressure area care, working on joints to maintain their mobility, and treating spasticity. All of this is important in optimizing the patient, and also time helps reduce the anesthetic risks. Early reconstruction between 9 and 12 months for recipient nerves in the injured metamere is mandatory because they behave like a peripheral nerve injury with motor end plate degeneration. But late reconstruction may be possible beyond 12 months or even beyond this, and the recipient nerve in the infralesional segment probably has a reflex pathway and therefore a motor end plate intact. So passive joint mobilization and functional electrical stimulation may increase the window of opportunity for reconstruction. The important thing is how we standardize and measure outcomes in tetraplegic hand reconstruction, and it's not clear from the literature exactly what the optimum methods are. It's important to look at a patient's physical well-being through the short form 36 or even the short form 8 questionnaire. Myometry to look at motor function, and sensory function needs quantifying with Sims-Weinstein monofilament pressure thresholds, but moving and static 2PD can be used as part of the ICSHT classification. ADL function can be assessed in a number of ways, either using a functional scoring system or using a performance tool such as the Southampton Assessment Protocol or the Moberg Pickup Test. Here are some websites for further reading should you so wish. Thanks very much.